As we continue with using data to drive culture and accountability, my name is Michael Friedman. I'm the Director of Activity and Mobility Promotion. As Dr. Hoyer mentioned, there are a number of ways, and we've demonstrated for you examples of methods we fed back data and information at the front lines. I'm going to focus more on how we share dashboards and informations to management and leadership to push the ball forward. To start with, these are examples of our dashboards for sustain and implementation. We know that documentation compliance is extremely important to driving outcomes. There's no way you can drive goals, and we've talked about the importance of documentation compliance. What you see here is our ability to feedback information across different units over a month, 3-month, and a trailing 12, as well as month-by-month views down below. In our Implement tab, we actually do things at smaller frequencies because we expect change to happen month by month. Whereas we move to the Sustain, we're more likely to see those changes happen quarterly. The concept of red, yellow, green is, of course, very identifiable for organizations to know if they're moving forward positively or if there are challenges or areas for which they might need to focus. We've also have AMP as a core metric. This is an example of our Executive Safety Quality Dashboard. You can see JHLM documentation compliance. In this case, for our Department of Medicine, is listed amongst major measurements that are considered by our hospital. Things like readmissions, MHACs, or hospital-acquired complications, mortality, the business continuity plan compliance. Just by being on the list with these other important elements creates a priority for activity and mobility promotion to be identified as a safety quality priority. And you can imagine when there are variances from this target, information and action plans are driven to others within the organization from our executive leadership levels. This inherently, as we've talked about, in making things a priority, make it louder, jump it up the accountability list, as well as increase awareness. All the things we were looking for to create a safety quality priority. This is how we look at low value PTOT consults. We can feedback this data by month, by attending, by organization. And in this case, you can see patients with an AMPAC score greater than or less than equal to 23. For both OT and PT. And you can actually, we know that we can drill down into these individual numbers, but this gives a concept of what percentage of consults were in these higher scores of AMPAC scores, which are consistent with patients being more independent. Also at a unit level, we're able to look at goal achievement. And so you can see here with goal achievement, you can see that people trying to achieve a 7 or 8, this category of what we would call walking outside the room. There were 6,240 days where someone had that goal, and there were 4,000 days people achieved that. And so you can see clearly we had 10,000 patient days that patient had an opportunity to work further. We do see this as somewhat consistent. There are a lot of reasons for barriers, but as you're working and setting goals, quality improvement goals, making people aware, we can see these are opportunities. By the bar graph, you can then see the line graph, which shows you the trend line of goal achievement in that bucket of 7 to 8. And you can divide your buckets in different ways. We split our buckets into 7 and 8, 6, which we consider walking in room, and then 3 through 5, which we consider edge of or out of bed activity and goal achievement. In our first run, our first big goals were documentation compliance. As you progress, you really now want to move towards how well you are pushing people forward. We go from that unit concept to the concept of a surgical pathway goal. This is specific for a post-op day of 2 for cystectomy, and you can see what is goal achievement on day 2, and you can start to drive into why that goal was or was not achieved. All of these things are items that you can drive and views that you can develop all based on having a systematic common language of function that is being recorded and is in your source data. These are all things that we've thought about as we developed our electronic medical record of the types of questions or views that we would be interested in. You then, from a practice, can start to move to just-in-time communication or communication on the floors. Our ultimate goal is to establish red and yellow flags. So, developing alerts like, does a certain patient have a mobility goal? If an AMPAC was not created, we would see that day they don't have a mobility goal. Did an individual patient over a 2 or 3 day period of time not achieve their ambulation goal? And we can see that that person's at a red flag. And so now we're starting to create dashboards by patient of alerts that in the morning a charge nurse could look and see patients that had certain actions that were red or yellow flagging that needed to be acted on. And these are related to certain operating mechanisms that are accomplished to overcome these variances. And then I know Dr. Hoyer showed some things like this, but we can take concepts of mobility goal achievement and compare it and correlate it with length of stay. And we can take this back to leadership to demonstrate the value of the program or that we're moving in the right direction. So what are our take homes? Bottom line, showing data is very important for QI. I would argue it's beyond important for QI and it's essential. Number 2, start basic and build to additional analysis as the project progresses. Dr. Hoyer showed you some really simple things you can do to drive data and feedback information. We know with mobility, awareness is half the battle. Just assessing function systematically moves the needle. That's the first step. As one of our nurse directors says here, she says, documentation compliance is what shows up when you're going to the gym, but mobility goal achievement is what you're doing and actually did at the gym. So it's a 2-step process in feeding back data. Are you documenting what you need to? And then are you actually pushing patients as far as you can? It's always great to correlate projects with outcomes. This is the opportunity to talk about the value and the relationship of your program with other major committees or other outcomes, whether they be length of stay, whether they be patient-related outcomes, readmissions. However, when you do that, you do need to control for those outcomes and make sure that you are accurately articulating what that relationship is. And if there's a plan for a larger scale implementation, it's important to define each metric carefully. You really need to have operational definitions that people understand, and you need to be able to document them and have them ready to be able to answer inquiry. The quickest way to undermine your activity is for there to be questions about the reliability of the data and the metric that you're feeding back. And so we go great pains to make sure it's accurate, it's validated, it's reported regularly, and that stakeholders have all had input as we develop new displays and new information. Thank you.
Hi, I'm Eric Hoyer. I'm a physician in the Department of Physical Medicine and Rehab at Johns Hopkins Hospital. I'm also the Vice Chair for Quality and Safety, as well as the Co-Director for the Activity Mobility Promotion Program here at Johns Hopkins Hospital. I'm going to be talking about using data to drive culture and accountability. So the place where this fits in is in this area right here that I've highlighted in red in the translating research into practice. And that's really the process of the evaluation, taking the data that you've been collecting and evaluating it, and then also producing reports so that you really can engage and get culture change, potential get additional buy-in, etc. So having data and then reporting on this is a really critical component of the quality improvement process. So there is a saying in quality improvement that you can't do QI without data, and it's critically important to move culture forward. And what we've been trying to do as part of our AMP program is we have met with individuals and discussed what are the specific questions or areas of success or that perhaps need improvement, and can we align data with those questions that those groups have had? And what I wanted to present right here were just some examples of some of those early reports that we used early on in our quality improvement process to really try to push that needle forward in terms of culture change and promoting activity and mobility on the hospital units. So this is an example of one of our initial projects, and one of the key concepts that we've always talked about is that just the awareness of function of patients is critically important. And to get to that, we feel that documenting for nursing what patients are actually doing in terms of their mobility is important. And so part of the quality improvement process involves engaging nurses in documenting on a regular basis that patients have a mobility score every day. And so this is a very simple graph that shows over the course of the first 3 weeks of the project that even within a few weeks, nearly 100% of the patients, we were able to get mobility scores on the patient. And that was really important to give that feedback to nursing so that we could drive culture forward. Another important strategy that can be effective is sometimes is to try to engage a couple of units at the same time, because sometimes having a little competition can be helpful, as well as also learning from a different unit about their successes so that you can also improve as well. So again, this graph is showing documentation compliance as an important metric as part of the AMP program. And you can see two different units. And when we started the project, you can see that unit that's depicted in the red color, started off better and was quickly able to get to a higher documentation compliance. But the blue unit was struggling. But really through a courses of weeks and talking about barriers and challenges and facilitators and ways to kind of push that needle forward, you can see that unit that's depicted in blue was able to ultimately match the same documentation compliance and even exceed the other unit as well. So again, having a couple of units and showing comparisons can often be an effective strategy. What's also early on, what we were doing is also giving feedback really at an individual provider level. I think there was a lot of concern that nurses, they've got a lot going on, and we really don't want to add additional burden. And this may not be feasible for them. And what we wanted to show is that that there are differences. That we had, for example, some nurses, for example, on Unit 1 on the top, that during a certain period of time they were able to document frequently, but that was different than on a nurse, for example, that I've shown below, even though that they work the same number of hours during the let's say for a few weeks. And really providing that data to the nurse manager and showing them that so that they can really go back to the individual provider and see, what were some of the barriers, or what were some of the maybe the opportunities also to to give kudos to that high performer was an important strategy as well to push that needle forward. This is sort of a similar concept as well. Rather than showing the total number of documentation at a nurse level, we were able to show what was the average Johns Hopkins highest level of mobility score. And again, really to show that variability across in a single floor. And you can see, for example, that we have a nurse, at the top who was averaging, getting their patients on average to some type of, between, transferring to a chair or standing level. But we also had, nurses that were averaging, patients were just still staying in bed. And again, presenting this data to the nurse manager, perhaps provided an opportunity for education, or again, a way to really give kudos to some of the nurses that were really doing an outstanding job. Additional data that we found really helpful in driving culture was showing fall rates. I think that we have a unfortunately a culture in the hospital sometimes where we don't want to push patients in terms of the mobility because it's going to lead to increased falls. So it was important to show that over time, over the project, we were not seeing an increased fall rate. And so this is showing that over time in the project that the fall rate was able to stay at least the same and not go higher as a result of increased mobility. One of the groups that we also needed to engage was the physicians. So for example, when we worked with the hospitalist group, one of the outcomes that they were continuously looking at is length of stay. And so just as a simple analysis, we showed the relationship between patients' highest level of mobility score and their length of stay, showing that when patients had higher HLM scores, their length of stay went down. Now, we realize that that's not necessarily causative. You know, perhaps that patient that had a higher HLM score was less sick, but still to see that relationship and to see this, the value potentially of that score, of that HLM score, to tell them something about that patient that had a relationship with something like length of stay was critically important. And I know that that was really helpful to get buy-in, for example, from some of the physician groups. And then similarly, also over the course of the project to show that, you know what, we are making an impact in terms of length of stay. You know, we're having increased discussion about mobility scores. That's being fed into care coordination rounds. We're starting to make earlier plans, for example, about discharge planning, things like that, as well as some of the physiological benefits of mobility. And we're starting to see an impact in terms of length of stay. And to be able to demonstrate that and to show that to the unit was really helpful to get buy-in from the providers. Thank you.